the end, we're going to have a collaborative quiz, okay, on which you guys can work together. You should get 100 on it. Okay, so what we did last time was we did filtration. Filtration is moving stuff from what fluid to what fluid? Blood to the filtrate, right? And now we're going to do reabsorption. It's called tubular reabsorption. You move stuff from what fluid to what fluid? Filtrate back into the blood. So metaphor that we use, dump everything out on the lawn. Now I'm going through the stuff on the lawn, and I'm specifically deciding what to bring back in. Yes? Okay. So what we are going to do is we are going to do basically transepithelial transport, right? Here's the tube, and here's the capillary. We're going to move it across the apical membrane, through the cell, right? Across the basal membrane, a little bit of interstitial fluid, and then into the capillary. The capillary is fenestrated in many places, but not all, right? So remember transepithelial transport from earlier this semester? Yeah? Okay, so last thing that we talked about last time is how do you move things? Well, we go back to the predictor that we had at the beginning of the semester. The cheapest, fastest way you can possibly move it, right? You wouldn't do active transport if passive would work, right? You wouldn't do primary active transport if secondary would work, right? You wouldn't use a carrier if you could use a channel. You wouldn't do any of those if you could diffuse it straight in, right? So the cheapest, fastest way that you can get the stuff across, right? So in each of these situations, even though I'm going to tell you how it's transported, I also want you to try to predict how something is transported. Like how would we reabsorb glucose? How would we reabsorb whatever? That make sense? Okay, so we are going to start with glucose. And remember that we said that glucose is basically money. We put money out on the lawn. How much money do you want to bring it back into the house? All of it if you can, right? But in this particular instance, there is a limitation of how much you can bring back in. And we talked about this briefly last time, right? We talked about glucose. Okay, so the mechanism by which you bring glucose back in is, remind me guys, secondary active transport, right? So briefly, let's talk about this. Remind me, what kind of protein is that? It's a carrier, and carriers are subject to saturation. They can get full, okay, so that matters, right? So we do a carrier, we do another carrier when we bring it back in. But of course, if it's the day after Halloween and you're 8 years old, how much glucose are you going to have in your bloodstream? Boatloads of glucose, right? Unless you're one of those damn families that like farms out the candy, you can have like 3 pieces a day. Screw you, man. This is how the neighbors do that. And my son is like, I'm so glad I don't live with those people. They are allowed to have 3 pieces of candy a day. You know what that would do to me? I would be a sneaky little bastard. I would be finding that candy. Yeah, they're allowed to have 3 pieces a day. I'm like, just like, let's just get it over with, right? Instead of 3 pieces a day, just eat it until you want to give it away. So you bring it back in, and then since it's subject to saturation, let's just talk about what would happen if you couldn't reabsorb it. Remember, if you can't reabsorb it, then basically what you do is bring an impermeable solute through the tube. And when you have an impermeable solute, what does it do to water as it goes through the tube? It sucks water back in via osmosis, and then it makes you pee a lot, right? So that is the reason that if you eat really, really sugary foods, the next day you'll pee a lot, but you probably won't notice. However, you will notice if you're diabetic because you're going to pee a lot of the time, okay? So that's glucose reabsorption. It's secondary active transport. That is the same mechanism of reabsorption for amino acids, some lactic acid, and some water-soluble vitamins. Most of them will use sodium to piggyback back in. Does that make sense? Okay, all right, so now let's talk about sodium ion reabsorption. Okay, this one gets a little trickier, so I want you to pay attention slowly and make sure you don't get lost in the early stages. We're going to do a 2-step sodium reabsorption. We're going to do PCT sodium reabsorption, and then we're going to do DCT sodium reabsorption. You with me? Okay, so I'm going to reabsorb sodium at the proximal convoluted tubule. How do we get sodium to move back in? It is active transport because your blood plasma is always relatively high concentration of sodium, but we still need sodium, right? Right? Remember, your extracellular fluid is generally going to have a pretty high concentration of sodium, right? So I tend to have to do active transport to get it to move back in. Everybody all right with that? Just because of the concentration gradient. All right, so now, what is moved where? At the PCT, the proximal convoluted tubule, you are going to reabsorb 65% of the sodium that you dumped out on the lawn. You're just going to bring 65% of it back in. But remember, it's active. You're going to pay to bring it back in, and you're going to, use active transport to bring it back in, okay? Now, we have no control over that 65%. That is the way it works. That is how much the proximal convoluted tubule brings back in, okay? So you push it back out. Now, why did we push it out at all? Because the filtration is not specific, right? It just fit through the damn holes. That's why it's out there, right? But you can select how much you want to bring back in ultimately. Not the 65%. 65% goes back in. But then at the distal convoluted tubule, I can select how much of the 35% to bring back in. Does that make sense? Okay. So I could lose, right, up to 35% of the sodium, right? No more than that. Does that make sense to you guys? Okay. Or I could lose less than 35% if I reabsorb the distal convoluted tubule. You guys got it? Okay, so let's talk about distal convoluted tubule. First off, the proximal convoluted tubule reabsorption is called non-regulated, yes, or obligatory reabsorption of sodium. You can't control it, yes? Okay, so let's talk about the distal convoluted tubule reabsorption of sodium. The distal convoluted tubule reabsorption of sodium is really based on the body's needs, okay? It's also based on some other factors. So this is called regulated reabsorption of sodium or facultative reabsorption of sodium. You with me? Okay, so what are some things that can control whether sodium is reabsorbed or not? Hormones that you already know, okay? Let's meet one of them again, and one of them is ANP. Why is ANP released? In response to what? Prolonged atrial stretching, right, which could be an indication of high blood pressure, right? So what it's going to do is it's released from the heart in response to prolonged atrial stretching. It is going to go to the kidneys, right? And what do you predict about what it would do to DCT reabsorption of sodium? Increase it or decrease it? Decrease it. That's exactly what it does. It decreases DCT reabsorption of sodium. Does that make sense? Okay. So what it's going to do is decreases regulated DCT sodium reabsorption. And it also inhibits aldosterone secretion. So when you secrete ANP, you don't secrete aldosterone because they would contradict one another. Does that make sense? And then it does one other thing that is not related to reabsorption, but is related to the whole blood pressure thing. What it actually does is it actually targets the afferent arteriole to help with blood pressure. What do you think it's going to do to the afferent arteriole? Dilate it. But that doesn't impact reabsorption. It impacts what? Filtration. It actually causes you to filter out more. Does that make sense? So it's sort of got a double whammy effect, right? It decreases reabsorption, increases filtration, right? Collectively, those will do what to your blood pressure? Decrease your blood pressure. Does that make sense? Okay, got it? All right, so the net effect is decreases blood volume and decreases blood pressure. Okay, so now let's talk about the other kind of situation in which I need to increase reabsorption, right? Not decrease reabsorption. So what kinds of stimuli can I use to increase reabsorption? So we'll talk about the stimuli and then we'll talk about the mechanism of increasing reabsorption. So any of these things could be a stimulus that will trigger increased reabsorption of sodium. You could have a decrease in blood volume. So see if that one makes sense to you. Increase in blood volume, could you, for instance, mitigate that by increasing sodium reabsorption? Does that make sense? Okay. You could have a decrease in cardiac output. That's not even a kidney problem, so why would the kidneys get involved? Because they're like, sorry about the heart thing, this is what I can do for you, right? I'll just give you some more blood to increase the pressure. Does that make sense? Okay. So it's not a kidney problem, but the kidneys are like a one-trick pony. They're like, hey, I'll help you with more blood, right? A decrease in blood pressure or blood flow to the kidney, even if it's not related to blood volume, even if, for instance, I went into shock, dropped my pressure really dramatically, what would the kidneys do? And they'll go, I don't know anything to do about the blood vessels, but how about I retain more water? Does that make sense? So the kidneys are basically this one-trick pony in which you say I got a blood pressure problem, they say I've got all I have is a hammer, and so everything looks like a nail, right? So they're going to try to increase blood volume. Okay, and then the other thing is that the kidneys also look, so the top three are looking at the blood, and the bottom one is looking at the filtrate. So the other thing that could trigger increased reabsorption at the DCT is by looking at an increased concentration of sodium in the filtrate. So the top three look at the blood, the bottom one looks at the filtrate. Okay, so now let's look at the mechanism. You ready? If I detect any of these things, what can happen is a mechanism that you already know. Okay, so for instance, the juxtaglomerular apparatus, our friend that nobody ever wants to talk about, right? The juxtaglomerular apparatus, if for instance it detects any of those things, either detects high filtrate concentration at the distal convoluted tubule or low pressure right here, right? What it will do is it will secrete the enzyme renin. We know what renin does. It converts angiotensinogen to angiotensin 1. And then what converts angiotensin 1 to angiotensin 2? ACE from the lungs converts angiotensin 2 to 1 to angiotensin 2. But even more important in this part of the story is that angiotensin 2 will cause the release of aldosterone. Does that make sense? And here's what aldosterone does. We've told this story before. We can just add a little bit more detail to it. Okay, so now I'm going to tell you what aldosterone does. We learned this story before, but now I'm going to give you a specific location. At the distal convoluted tubule, in the presence of aldosterone, what will happen is aldosterone will activate this transport protein. And what the transport protein will do is reabsorb sodium at the expense of secreting potassium and H+. Right? That's what you already knew. You just didn't specifically know where in the kidney it would affect. And now I'm telling you what it does is it controls reabsorption of sodium at the distal convoluted tubule, primarily in response to pressure changes in the afferent arteriole. Right? Does that make sense? Okay. So aldosterone causes increased regulated DCT reabsorption of sodium in the DCT. And the net effect is increased sodium, therefore increased water reabsorption, increased blood volume, and what blood pressure? Increased blood pressure. Okay. Now, the reminder is that angiotensin 2 also raises blood pressure by vasoconstriction, but we're concentrating on the kidney right now. Good? Okay. So the opposite is also true, by the way. If you detect high blood pressure at the kidney or high osmolarity of the filtrate, it will decrease renin concentration, decrease angiotensin, decrease aldosterone, and increase sodium loss at the urine. So, and note to self, this is not reabsorption, but this happens because of aldosterone. So we're going to talk about these specifically when we get to the secretion step, right? Okay, it's just that you swap it for something. Okay, so now let's talk about potassium ion reabsorption. Remember potassium? I don't know if you guys remember this. Potassium is the one that we have trouble absorbing all of. So we generally reabsorb about 90% of the potassium, but then we can lose it from there. So here's the deal. Potassium ion reabsorption occurs primarily at the PCT, proximal convoluted tubule, and it occurs by active transport. And there is no regulated reabsorption of the rest. We always lose at least 10%, but then we can lose more, can't we? Does that make sense? Right? So we reabsorbed 90%, but then what if aldosterone is present? Aren't we going to go down from 90%? So we usually end up reabsorbing collectively about 86, 85% of the potassium. Now, put this back into your life and make it make sense. What are you more likely to be deficient in, sodium or potassium? Potassium. It's for a couple of reasons. First of all, sodium is abundant in our food because we like it. And second, we can't actually reabsorb all of the potassium in our kidneys. We're always going to lose some of the potassium that's in our bloodstream, always. Does that make sense to you guys? Okay, all right. So how about these negative ions? So we were moving primarily positive ions. Well, if you really, really work on moving positive ions by active transport, you don't have to work on moving negative ions because they follow the electrochemical gradient. So if you move massive amounts of sodium from where? You move it from the tubule to the cell, to the interstitial fluid, to the blood plasma, and you also move massive amounts of potassium on purpose, then you create an electrochemical gradient and the negative ones just follow everywhere they can find a channel, right? Does that make sense? So specifically, we don't usually have to worry about reabsorbing the bicarbonate ion and reabsorbing chloride ion. So those usually just follow what the positive ions are doing. Is that okay? Okay. Now, let's talk about water reabsorption. So we did glucose, we did sodium, potassium, and then we did our negative ions. How about water? Well, we do a hell of a lot of water reabsorption because we filter out, remember, about 180 liters of water per day, but we don't pee 180 liters. We pee 1 to almost 2 per day. So depending on how much water you've taken in and other things. So how does this work? Well, generally, because solutes suck, as you actively move solutes, you get the passive movement of water, right? Does that make sense? With like one little exception. So here's the deal. Now, just to make it conceptually make sense and go all the way back to when we talked about osmosis. Osmosis is simply water moving down water's concentration gradient, right? Okay, so what happens when I move, let's just follow sodium for a second. If I move massive amounts of sodium from the tube into the cell, into the interstitial fluid, into the blood plasma, what I'm doing is as I increase sodium concentration, I decrease water concentration, right? So do you see that I'm actually creating a gradient for water to move down by moving all of those ions, right? And when you do that, you don't have to worry about water transport, right? So the deal is that in the PCT, if you reabsorb 65% of the sodium, you generally reabsorb 65% of the water too. And you don't have any control over that, just follows, right? So solutes suck and sodium sucks the most. Okay, but in the DCT, we have a mechanism of uncoupling water from sodium transport or putting it back together. Because are there situations in which you might need to reabsorb sodium, but you don't need to reabsorb water? What if I was fasting, but I was drinking boatloads of like lemon water, right? Do I need to reabsorb the water? No. Do I need to hold on to all the sodium that I can? Hell yes, right? So there are situations in which you need to uncouple sodium reabsorption from water reabsorption. You can't do that at the PCT. You got no control over it. You can do it at the DCT primarily because of ADH. So let's put that together. Okay, so what happens with sodium reabsorption, water reabsorption, is that water passively follows sodium ions into the bloodstream. So this would, for instance, right. So as you move solutes in, you move water in, right? But that's called non-regulated reabsorption of water. You're going to do 65% of it no matter what. But at the DCT, you can choose how much of the 35% you want to reabsorb or not. Does that make sense? Okay, so let's talk about that. The reabsorption of the remaining 35% will happen at the loop and the DCT, and a little bit the collecting duct, the part of the collecting duct that still has vessels close to it. But remember, you actually don't need vessels to do osmosis, right? You actually can move stuff into fluids and then it can move. Okay, so the reabsorption of the remaining 35 can be regulated, and it occurs in the DCT and the collecting duct. Okay, so the cells of the DCT and the collecting duct must contain ADH. Here's what ADH does. ADH allows for water to follow sodium. In the absence of ADH, sodium moves by itself. In the presence of ADH, water moves with sodium. Does that make sense? And so you guys remind me, where does ADH come from? Posterior pituitary, exactly, okay? Now, here's what happens. I want to think about two different situations, and I want to think through something that you've known since you were a little kid. So, you're going to get your money out of physiology because I want to tell you that if you drink more water, you pee more. You needed me for that, didn't you? If you drink less water, you pee less. However, there are details in the middle that are important that are physiology-based. It's not that if you drink more, it goes into your urine and you pee more. It's if you drink more, it causes a hormonal response, which ends up in your urine. Okay, so let's talk about that. So if ADH is low, so sit and think for a second. Under what circumstances, normal physiology, a normal day, under what circumstances would a person's ADH be low? If you are doing well. Think about it. Just normal physiology. Don't do anything strange. Just get up one day and do whatever it takes to make your ADH be low. What would you need to do? You need to drink a lot of water, okay? If you drink a lot of water, then what it does is it makes your blood relatively hypotonic, right? Hypoosmotic when it goes to your brain, right? And then your hypothalamus detects that and it says, hey, got plenty of water, don't need to release ADH. And when it doesn't release ADH, what happens to that 35% of the water? You lose it. Does that make sense? Because ADH allows for water to follow sodium. Even if I'm reabsorbing the sodium, I am not going to reabsorb the water. Got it? Okay, so It is true that if you drink more, you pee more. But the relationship is if you drink more, you inhibit ADH secretion, which inhibits DCT reabsorption of water, which is why you pee more. Got it? Okay? All right, so if ADH is high, again, under what normal day-to-day circumstances would your ADH be high?
Drink less water.
Drink less water. That's probably my everyday situation, right? First of all, I hate going to pee in public places. It grosses me out. And second, I don't have time for that stuff, man. I got stuff to do. And also, coffee is delicious. Okay, so if ADH is high, like in Melanie, then your water reabsorption is high. But why? So if ADH is high, what's going to happen is basically I'm not drinking very much water, and I deliver relatively concentrated blood plasma to my hypothalamus, which says, hey, that's too much, right? And what it's going to do is it is going to cause the posterior pituitary to release ADH, which targets which part of the nephron? DCT, targets the DCT of the nephron, right? And what it does is ADH allows for water to follow sodium at the DCT. Does that make sense? And so you're going to reabsorb more water. So, note to self, you needed an entire semester of physiology to note that if you drink less, you pee less. You are welcome. You are so welcome. Okay? Okay, so now another situation, by the way, in which ADH can be super duper low and cause you to pee a lot is, remember diabetes insipidus? Remember that one? That's a patho situation. Okay, so ADH, by the way, also causes the thirst response. So if you don't drink a lot, you don't pee a lot, and you get thirsty. Amazing. I feel really brilliant right now. Okay, so ADH release is controlled mainly by the water concentration of the blood being detected in the brain. So we talked about that. Okay, so what about other stuff that gets dumped onto the lawn? So we talked about glucose, of course. We talked about sodium. We talked about potassium. We talked about negative ions. And then we talked about water. What about stuff that doesn't fit into any of those categories? Lipid-soluble substances, they do whatever the hell they want. Your kidneys are not very good at getting rid of lipid-soluble substances. Because even if they get pushed out onto the lawn, they will move right back in down their concentration gradient if they want to. So our kidneys are really not good at clearing lipid-soluble toxins or excesses from our bloodstream. They really aren't. Okay, so why can't you eat like a super high-fat diet and then not have to worry about it because you pee it out? Because you don't pee it out, right? It just stays with you. Okay, all right, so what about toxins? If lipid-soluble toxins exist, they're hard to get out of the body unless the liver changes them to be less lipid-soluble, and then the kidneys. So those two work together. The liver and the kidneys can be partners in getting rid of crap from the body, okay? Now, what if you don't have any mechanism of bringing it back in at all? So if you dump it out onto the lawn, but you don't have a transport mechanism, it's not lipid soluble and it doesn't have a transport mechanism, right? It can't diffuse, it doesn't have a transport carrier, it can't do endo or exocytosis, then basically it ends up staying out there, right? Because filtration is general and reabsorption is specific. So if you dump it and you don't have a mechanism of bringing it back in, it generally stays out there. Creatinine from creatine phosphate gets dumped out but doesn't have a mechanism for bringing it back in. Uric acid gets dumped out but you don't have a mechanism for bringing it back in. Urea is reabsorbed incompletely because it can help regulate the pH, but we won't talk about urea in much detail. Okay, so third phase is the easiest one. It is tubular secretion. So we did glomerular filtration, tubular reabsorption, and now tubular secretion. So again, tubular secretion is going to move stuff from wet fluid to wet fluid. Blood to filtrate. Yes, blood to filtrate. Good. And it occurs primarily at the distal ends of the thing, the DCT and the collecting duct. That's where most of your secretion occurs because you're kind of finished with like filtration and reabsorption. And now you can check to see if you need to get rid of anything. And remember, our metaphor for secretion was filtration was dump everything out on the lawn. Reabsorption was pick through it specifically, decide what to bring back in. And secretion is open up all the cabinets and look under all the beds and see if you can find any more cat boxes and then take them out, right? Okay, so that's what we're doing. So it gets rid of certain things, secretion, ammonium ion, penicillin, phenobarbital. urea and uric acid that might have been reabsorbed, but now we rethink it and we're like, no, we really don't need as much of that. We're going to get rid of it. And also excess potassium. Remember that in the presence of aldosterone, you will actually get rid of excess potassium, right? And or H+. This is one regulatory mechanism for regulating your blood pH. Okay, so the main kidney control over pH is by deciding how much H+ to secrete. Now, not all H+ is secreted with aldosterone. Some of it is not aldosterone dependent. Okay, so here's what happens. Yet again, one more place in the body. We are going to do this equation and shift it to the right. This is going to happen inside the tubule cells. Okay, I'm going to take carbon dioxide. I'm going to shift it to the right to make H+ and HCO3 minus. But now the kidney can decide what to do with each one of those, right? If your blood pH was slightly acidic, what would you do with the H+? Which tube would you put it into? The tubule, so you pee it out, right? If your blood pH was too basic, what would you do with the H+? Bloodstream, right? Now I've got the bicarbonate ion, right? The bicarbonate ion has a slight buffering capacity. If your blood was too acidic, what would you do with the bicarbonate ion? Dump it into the bloodstream. If your blood was too basic, you dump it into the pee. Does that make sense? So the kidney forces this reaction and then decides what to do with each one. So even if the problem didn't arise because of carbon dioxide, the kidney will help it, right? I don't care how your blood pH got to what it is. The kidney can help to manipulate the blood pH. Does that make sense? By both directly secreting the H+ that's in the bloodstream and then forcing this reaction and figuring out what to do with each one. Does that make sense? Okay, so if, for instance, it was too acidic, then the H+ would be actively secreted and the bicarbonate ion would be retained, right? If it was the opposite, you would do the opposite, right? Okay, so that low blood pH could have been due to any number of things. It could have been due to a deficiency, carbon dioxide, too much H+, too little bicarbonate ion, whatever. The kidneys will still do what they do with it. Okay, does that make sense? So you see that really the kidney and the respiratory system are working in concert to regulate your blood pH, right? Those two are working together. Okay, so summary. And we are through the hard parts now. The summary is this. Okay, before we get into what happens in the distal convoluted tubule, what happens in the proximal convoluted tubule is primarily which of the processes? Filtration, reabsorption, or secretion? Reabsorption. But it's non-regulated reabsorption, right? You don't have any control over it. So what happens in the PCT is what happens in the PCT. And what I do is I reabsorb how much sodium? 65%. How much water? 65%. How much potassium? 90%, and then you can move down from there, right? How much glucose if I can? All of it, 100%. Got it? Okay, so I don't have anything that I can really do to the PCT under most circumstances. There are some drugs that can affect the PCT, but we won't talk about those quite yet. We're going to talk about diuretics in a second. But in the DCT, you can manipulate what happens, right? So in the distal convoluted tubule, if ADH and aldosterone are present, let's see what will occur, okay? If ADH and aldosterone are present, then what you're going to get is sodium reabsorption from filtrate to cells to interstitial fluid, ultimately to blood plasma, right? But of course, the movement of all of those positive ions must be canceled out. So either you have to have negative ones follow them or swap them for other positive ones, right? That makes sense? Okay. So what will happen is as you move massive amounts of sodium in at the distal convoluted tubule, you'll either have chloride and bicarbonate follow it, right? Or you'll swap it for these two, right? H+ and potassium. Okay, so a summary of a summary. Here you go. What is going to happen at the distal convoluted tubule under the influence of ADH and aldosterone? Oh, I didn't talk about water. Water will move in if ADH is there, remember? Okay, so one more time. What's going to happen, the summary of the summary, in the distal convoluted tubule, in the presence of aldosterone and ADH, you are going to reabsorb sodium, chloride, bicarbonate, and water. Yes? And you are going to secrete which things? H+ and potassium. Does that make sense? Okay, and if you manipulate your level of aldosterone, you can manipulate your level of most of those things. Okay, that good? Okay. Okay. Questions? All right. So last thing to talk about is final volume of urine and diuretic function, and then we'll just like briefly talk about kidney stones. And then we'll do a collaborative quiz in which you guys get to work with each other. You should make 100 on it, unless, of course, you can't hit a button right when I tell you the answer, okay? Then that's on you, right? I ain't going to negotiate if your fingers are dumb. What? You do have to hit submit, yes. Okay, so your final volume of urine is usually, and it varies, right, dramatically based on what you do. It's usually about around 1 liter to almost 2 liters per day. It is dramatically affected by your blood pressure because this relationship, increased systemic blood pressure, increased GFR, which increases which of the 3 stages? Filtration, reabsorption, or secretion? Filtration, exactly. Does that make sense? Of course, if your blood pressure is too low, then you're going to release the renin and angiotensin aldosterone system, right? Okay, and that would, of course, decrease your urine volume so that you could actually have more blood. Okay, so here's the other one. We already talked about this one. I just want to put it together just a little bit more slowly. So your blood concentration, the amount of dissolved solutes versus water in your blood, right? You're constantly monitoring that to figure out whether you should pee or not pee, right? And so again, here's the relationship that you get. If you drink an excessive amount of water, it's one of those days in which you decide you're going to like drink water, tons and tons of water. Like, I'm going to drink 16 glasses of water a day. And then you're like practically wanting to yak because of all that water. So let's say you're doing that. You drink an excessive amounts of water. The water concentration in your blood increases, right? It's detected by the brain. And then it inhibits secretion of ADH. And no ADH will affect which part? Non-regulated or regulated reabsorption of water? Regulated reabsorption of water, primarily because the lack of ADH makes water not be able to follow sodium. So you secrete a large amount of dilute urine, right? Okay. And then last but not least, if you are dehydrated, remember your water concentration of your blood will decrease. It will be detected again by the brain, by the hypothalamus of the brain. ADH will be secreted, and ADH will do what? Increase or decrease regulated reabsorption of water. Increase regulated reabsorption of water where? In the nephron. DCT. Yes, DCT of the nephron. And of course, you're going to pee a small amount of really, really concentrated urine. Okay, so now let's talk about other things that impact how much urine you produce. One of them is temperature. When you are exposed to high temperatures, what happens is you tend to cause more blood to go to the periphery and to the surface, right? And it will activate your sweat glands. And then you are going to lose both water and sodium as sweat, which will, of course, change the osmolarity of your blood, right? If you lose it as sweat, it came out of your bloodstream. So then that means that, just a second, that means that the blood that is going to your brain is going to be less concentrated, right? So it should make sense to you that if you sweat more, you don't need to pee as much, right? So as the fluid in the body decreases, ADH and aldosterone are going to be secreted, and you're going to do more reabsorption of water and sodium, right? Does that make sense? And so you pee less. So if you sweat more, you pee less. Go ahead.
So is that external temperature only, or does that also apply to internal?
It does apply to internal temperature. External temperature is where you're going to normally encounter it. But of course, if you had a fever, right? Anybody sweat like crazy when they have a fever, right? Have you ever like sweat so much like all the way through the sheets, right? So it doesn't matter where the body temperature increase comes from. It can activate the same response. Everybody okay? Okay. When exposed to low temperature, this is the camping problem. What is going to happen? My family camps a lot. Actually, we just bought an RV last year, so we camp in style now. We have been camping for decades. And so when exposed to low temperature, what's going to happen is you're going to pee more. And it is super annoying, right? Because you got to find your damn shoes in the middle of the night without waking up everybody else in the tent, right? And if you were a girl, you were going to pee on your shoes. You better bring your pee shoes when you go camping, right? Because you know it's unlikely that you're going to be able to find a tree that like you can do this with, right? I wear my husband's shoes. No, just kidding. Shoes are really big and they're really easy to find. He's like 6'6". So here's what happens. When you are cold, You do peripheral vasoconstriction, yes, to keep the warm blood here. When you do that, what happens to GFR? You increase pressure in the abdominal pelvic cavity and you increase GFR. You actually produce more pee. The most irritating thing in the world is that the colder you are, the more likely you are to have to pee, which means you're going to have to like take your cozy clothes off your junk, right? That's really unfortunate. I would like to talk to the management about that one. So your urine volume increases because the pressure in here increases and increases GFR, right? You can explain that to your family as they have to get up. They're not going to care. I try to explain all this stuff to my family, and they're like, okay. So let's talk about diuretics. Okay. So before we get into diuretics, tell me under what circumstances might someone be prescribed a diuretic? Like what do they for?
Edema.
Yeah, edema when you're building up too much fluid. What else? Most people are prescribed diuretics because of hypertension, heart problems, congestive heart failure, too much pressure in the cardiovascular system. Okay, is a really common mechanism or reason for prescribing diuretics. You could also have, for instance, edema, built up of fluid. You could also have diuretics prescribed because you're retaining fluid because you're taking like prednisone or something. You need a diuretic for that reason, right? Okay, so diuretics are trying to clear some of the fluid out of your body, quite often to drop your blood pressure, but not always to drop your blood pressure. So let's talk about how they work. Okay, so if we are going to impact how much pee you produce and therefore your blood volume, the most effective ways to do it are to affect how much sodium and water you reabsorb, right? Okay, you can directly target sodium or you can directly target water, right? But either one is going to work. So we've got two different times that we reabsorb sodium and water. We've got PCT reabsorption and DCT reabsorption. PCT reabsorption is what percentage? 65%. If we can inhibit PCT reabsorption, we can have a really massive diuretic effect, yes? That makes sense? If we can inhibit DCT reabsorption, we can go up to 35%. We're not as massive. So there are drugs that treat both places, and they have sort of unintended consequences, especially the first ones that are really powerful. So listen to this because it gets a little confusing. Okay, so the drugs, the diuretics, like Lasix, that are really powerful and really good at diuretics, are also potentially pretty dangerous. What those do, the reason they're so effective, is that they inhibit PCT reabsorption of sodium. Now, I told you it's non-regulated reabsorption. I mean that you can't regulate it. We did make drugs that can regulate it, though, right? Okay, so what they do is they inhibit the 65% reabsorption of sodium at the PCT, and so water doesn't follow it. Does that make sense? Okay, now, why is that problematic? The reason it's problematic is that if you don't reabsorb it at the PCT, you are gonna send it through the tube, and you're gonna send boatload of it to the DCT, okay? And the DCT is going to try to reabsorb the entire 35%, right? So you're definitely going to release aldosterone under that circumstance because you've got too much sodium in your bloodstream. You're going to release aldosterone, and you're going to do sodium reabsorption, but it's going to cost you something. It's going to potentially mess up your blood pH, and it's definitely going to mess up your potassium concentration. So these are really, really effective, but they make you lose dangerous amounts of potassium. So, for instance, people are not given these as maintenance medications to go home on, right? But in the hospital, in an inpatient situation, you can be given these, but what will you probably also be given in an IV? A potassium drip. Exactly. And then they are going to look at your blood chemistry pretty damn frequently to make sure that as your blood pressure is dropping, we are not jacking up your blood chemistry. Does that make sense to you? Okay. So these are really, really effective diuretics, but they are risky, right? You do not want to give them unless you actually have the capacity to monitor blood chemistry. Does that make sense to you guys? Okay. All right. Now, the one that is not as risky but also isn't as effective are the ones that affect DCT reabsorption. Now, they can only go up to 35%, but of course, if you inhibit this, right, you are a potassium-sparing diuretic. Does that make sense? They don't do anything to the 65%, but what they do is they inhibit this at the distal convoluted tubule, and then you're not going to reabsorb this, so you're not going to actually drop your potassium concentration, right? Does that make sense? Okay, so these, like spironolactone is one of these, and they interfere with the 65% reabsorption. So you are always going to lose a little bit of extra sodium and water from the body. It's not going to be anywhere near as effective at regulating your blood pressure, at least acutely, but you can go home on this medication, right? That makes sense? Okay, all right. And then the last one is the one that is not usually given as a prescription medication. This one, the ones that I know of, there might be others, are given as over-the-counter medication. So, for instance, women during a certain portion of their menstrual cycle sometimes retain a whole bunch of water. And so you like retain so much water that you have to like go up a pant size and can't get your rings off, right? It's just water retention. Because you know you didn't gain 15 pounds within the last 48 hours. It literally did not happen, okay? So what some women choose to do is they choose to take an over-the-counter diuretic that's like part of Motrin, and there's like Diurex pills, okay? So here's how these work. They're osmotic diuretics, because what you're doing is you're taking in something that you know will get filtered out and has no reabsorption mechanism. And then as it goes through the tube, it's going to kind of act like glucose in a diabetic, right? It's going to pull water out of the fluid into the tube, right? So make you pee more and drop the water concentration in your body. Does that make sense to you? So they're called osmotic diuretics. The one that I know about is mannitol. It will get filtered out but can't get reabsorbed, and it ends up in the tube. Now, are these potentially dangerous? Not if they're used as indicated on the package, but they do get used by people sometimes when they are bulimic or anorexic. You can kill yourself with diuretics. The reason you can kill yourself with diuretics is because when you're getting rid of fluid, remember that ions go with the fluid. So first off, when you're getting rid of excessive amounts of fluid, you can drop your blood pressure to the point that you can go into circulatory system shock. So that alone can get you, right? And then if you're using these massively, which sometimes do when people are abusing them because of anorexia and bulimia, when you're using them really, really frequently, you can also cause ion imbalances, because potassium, calcium, and sodium will follow, and you can get hypokalemia, hypocalcemia, and hyponatremia associated with this. So even though they're sold over the counter, you can definitely cause problems if you use them sort of off script. Does that make sense to you guys? Okay. All right. Last little tidbit is let's talk about kidney stones for just a second. Okay. So kidney stones are renal calculi. They are when you have solid crystals, ionic crystals, that actually build up, usually in your minor or major calyces, although sometimes they can form in your ureter. Regardless of where they form, unless you have some kind of intervention, and they have like little sonar things that can break them up a little bit, but even if you break them up, unless you have surgical intervention, you're going to have to pass those through your urethra. And it ain't pleasant. This is the one instance in which the shorter urethra of females is an advantage, right? In every other instance, we get more UTIs and more everything because of the shorter urethra and the location. But in this instance, I'm really glad that the urethra is not 8 inches long, which it is in males. I'm not saying the penis is 8 inches long because I was not born yesterday, but the urethra, all the way from the bottom of the bladder out to the external urethral orifice, is about 8 inches long. Okay, so let me show you what these bastards look like. Oh, look at them. This is not science naming. Just look at them.
I like it.
I've got some of these in my office. They're amazing.
You do.
I do. I have so much weird stuff. One of my students last semester brought me her placenta, and I preserved it. And then I got stones of all sorts. Yeah, I want it.
remember that from anatomy, you talking about that.
Why wouldn't you want it? We wanted a placenta for anatomy. She wasn't using it anymore. I preserved it. She told me she didn't want her name on it, but she did want, to be able to tell people that her placenta was in there. You can't buy them. I didn't tell my boss either, and don't you tell her. Don't you dare. That's why the anatomy lab is really good, because I don't really ask for permission as often as I ask for forgiveness. I'm like, I did this. Okay. So let's talk. I used gloves. I detoxified it. I did everything. Don't you even worry about it. Okay. So she froze it for me. And then like 2 weeks after she had the baby, she brought it to me. Okay. So why do you not want to see what a placenta looks like? They're amazing. You were dependent on one. Have some respect. Okay. So renal calculi. Let's talk about how those things form. So you can have a metabolic or genetic predisposition to renal calculi, just like you can anything. But basically, if you increase the concentration of certain ions in your bloodstream and therefore in your urine, you will increase the likelihood of renal calculi. Okay. So if, for instance, you are not taking in a lot of fluid, then of course your ions are going to be more concentrated, right? And that increases the likelihood of forming these ionic crystals, right? So I'm just saying, if you drink more, you're less likely to form kidney stones, right? Okay. So drink more water. I'm not talking about alcohol. Oh, I forgot something. I'll have to go back in just a second. I'll tell you about how alcohol is diuretic in just a second. Okay, so abnormally alkaline or acid urine change the pH. You actually change the ionic compound formation. So if you drink a lot of sodas, that makes abnormally acid urine. And then last year, the first time I noticed it last year, people started paying double and triple for alkaline water. Did you see that all over the place? You do not need alkaline water, right? You have a respiratory system and a urinary system to manipulate the pH of your blood. And if you take in abnormally alkaline stuff, you can jack up your system, right? So unless somebody told you you needed alkaline water that had a degree, right? And I'm not talking about David Avocado Wolf. Don't ever repost anything that charlatan does. I have a friend who constantly posts David Avocado Wolf things. I had to block her. So I was like, we are going to argue? She posted a big anti-vax thing from David Avocado Wolf. I was like, okay, so anyway, abnormally acid or alkaline urine, ingestion of excessive amounts of mineral salts, but not usually the good ones, will get you. Excessive amounts of sodium, excessive amounts of potassium. You don't want to cut sodium oxalate, sodium urate, potassium oxalate, potassium urate. That'll get you. And then what if you have overactive parathyroid glands? You're going to have too much calcium in your urine, right? Too much calcium in your blood. And then soda consumption. And the reason I put a question mark there is because here's what we know about soda consumption. In people who have a predisposition to forming renal calculi, soda consumption is going to exacerbate it. In someone who's never had renal calculi before, you may be able to drink sodas without getting it. So we do know that there is a direct correlation between soda consumption, but it's not causation in every person, right? Okay, so how do you prevent getting those little buggers? You drink plenty of fluid, especially before bedtime, because the stuff in your minor and major calyces are just going to sit there overnight, right? And you limit intakes of certain ions, anions, but not calcium. You know you need calcium, right? So you don't want to limit the intake of that, even if like the thing is primarily calcium. Okay, let me go back to this just real quick. I forgot about these two diuretics. I want to talk about why alcohol is diuretic and why caffeine is, and then we'll just talk about dialysis briefly, and then we'll start on the quiz. Okay, so why is alcohol a diuretic? Alcohol is a diuretic because it inhibits the secretion of ADH from the hypothalamus. So really, alcohol is a diuretic because it's an anti-diuretic, right? Does that make sense? Okay. And then, why is caffeine a diuretic? Caffeine is a diuretic because it increases your blood pressure. And so, which part would it increase? If it increases your blood pressure, it increases filtration, reabsorption, secretion. Filtration, right? Increases filtration. So if you really want to be like a racehorse, you take in a really sweet Irish coffee, right? Lots of glucose, lots of caffeine, lots of alcohol, and then you get close to a bathroom, all right? Because you're going to pee, okay? Does that make sense? Okay, last tidbit is just reminding you that we already learned about dialysis. And dialysis, here's a dialysis machine. Dialysis is basically taking your blood that is not cleansing itself via the kidneys and sending it through a machine that has a permeable membrane on one side and solution on the other one. And when we talked about dialysis before, I sort of implied that it only cleansed urea. It doesn't. If you make the membrane permeable to almost anything, then you can move it across via diffusion, right? It doesn't move anything via filtration, and it doesn't do the three-step process that we talked about, right? It's simply making a membrane that is permeable, right, to whatever you want to move across. You get one shot at doing it, right, and then you're going to dump it, right? It is used in instances in which your kidneys are failing you. That's what it's doing. Does that make sense? Okay, so go ahead and get out your device, and we'll do a collaborative quiz for you guys. You should make 100 on it. If I were you, I would get together with some people that you might want to talk to. Collective knowledge is nice in this situation, even a little close so that you can speak to them. You can have your notes open, but if you have your notes and look through them for everything, you'll run out of time for the whole quiz. So I would rather you talk to a neighbor than look up everything on the notes. Good? Okay. Ready, Freddie? Okay. Oh, did it? Oh, hold. Did it not start for your class? Okay, hold on.